Brent Beasling. I'm the medical director for St. Luke's Care. Today we're going to be talking about heart failure. We have two specialists with us from Cardiovascular Consultants, Tony Migalski and Bethany Austin. I really appreciate both of you being here with us today.
Thanks.
So let's kind of get started just in the general area of heart failure. And Tony, I know this is an area you've worked on a lot. You've worked on the heart failure order set a lot along with your colleagues. There's been a lot of input on that. We also know that CMS is auditing us all the time on how we're doing with heart failure. We have quality measures in heart failure that are really critical that we hit every single time. Studies show that when you use an order set for heart failure, you actually hit those quality measures more often, as well as having better patient outcomes. Decreased length of stay and less chance probably that the patient's going to be returning to the hospital as well. So Tony, if you don't mind just real quickly kind of taking us through the heart failure order set, things that you think are really critical that particularly a general internist who's trying to use this might know or need to know, and what things that you would recommend we think about. When do I need a cardiologist involved? So take us through this.
Well, Brent, thank you. The order set is, we've tried to pull out guideline and evidence-based criteria or questions that need to be answered when someone's admitted with heart failure. So while it's somewhat long, I think it touches on all the points. Firstly, it touches on, laboratory studies that you need to keep your eye on. Your creatinine and your potassium on a daily basis. Most importantly, I think it touches on the importance of ACE inhibitors and beta blockers. And there's a list here of ACE inhibitors that you can use. Dosing, targets, as well as reasons why, if you don't use them, you need to document. And as you said, there are performance measures that we're being looked at or followed by that we have to pay attention to. And one of the biggest things is if you're not, and there are good reasons why people don't take an ACE inhibitor or can't take an ACE inhibitor or angiotensin receptor blocker. We just need to document that.
Well, I'm glad you said that, because I know that when I don't use something, it's not the first thing in my mind to actually write down why.
Yeah, you need to be reminded, and it's a nice checklist in your own mind to say, okay, why is this patient on an ACE inhibitor and ARB? If they're not, why not? Maybe there's probably a very good reason. But again, we need to document that.
So my understanding is these are based on guidelines?
Correct.
And have there been any recent changes?
I think one of the big changes is that ACE inhibitors or angiotensin receptor blockers are considered equivalent. In the past, you had to be ACE inhibitor, intolerant before you could use an ARB. So if someone comes in on an ARB, that's acceptable. The beta blocker issue has not really changed. 3 acceptable beta blockers: carvedilol, metoprolol, or bisoprolol. We mainly use carvedilol and metoprolol here as well as in the U.S. But the aldosterone receptor blockers are being increasingly utilized, and there are recent clinical trials that show benefit in class 2 patients, where previously we had been using it only in advanced heart failure patients.
That's good to know. Well, Bethany, we asked you here because you're the champion of the vasodilator order sets for congestive heart failure. And take us through, if you would, a little bit about the development of the order set, the order sets, because there's a couple, the articles that support the development of these order sets, and where we are with this issue of kind of advanced congestive heart failure or congestive heart failure that's really critical in the CCU.
So vasodilator therapy in advanced heart failure has been a long-standing pillar of therapy going back to the 70s, but had fallen out of favor somewhat with concerns about lowering blood pressure. But in fact, with the mixed veno and vasodilation effects of particularly IV vasodilators, nitroprusside in particular, we're able to diminish afterload and redistribute into the venous system without a significant effect on the blood pressure, predominantly by increasing stroke volume and cardiac output in that manner. Because you are increasing the cardiac output, there isn't typically a compensatory tachycardic response, which is one of the nice benefits of this therapy. It's essentially energy neutral with respect to myocardial oxygen demand, which is one of the reasons that people may select it as an alternative to inotropic therapy for advanced heart failure, which, as you know, does have side effects, both with respect to tachycardia, dysrhythmias, and it does increase your risk of mortality in the short term and the long term. There's an excellent article in the Journal of the American College of Cardiology in 2008 that did show benefit in advanced heart failure patients with invasive hemodynamic monitoring in a dedicated cardiac unit, which is how we've set up our order sets as well. And in fact, that are both the intravenous and the oral vasodilator protocols for rapid titration and the attempt to transition from the intravenous to oral therapy are based on that study, which showed significant benefit. And also did have a nice representation of how the physiology with vasodilation, if you can defer inotropic therapy, does predict or changes your relative risk of mortality compared to inotropic therapy.
So most of the time when a patient is coming in for heart failure, we're probably not going to be using these. What type of patient are we going to use those in?
Sure. I think for kind of your run-of-the-mill average heart failure patient, you're going to be looking more at these order sets and doing kind of standard initiation and more gentle titration of ACE inhibitors and our standby oral vasodilators. We really think of these kinds of aggressive, rapid, and potent vasodilation protocols for patients that are essentially in shock. It may be chronic shock because they're chronically in severe heart failure, but they're requiring Swan-Ganz monitoring, they're in the ICU. You really want to maximize the benefit that you can give to them. They often do have marginal blood pressures, and they do need the close monitoring of nurses who are able to watch them minute to minute and monitor them for side effects of the therapy.
So let's kind of walk through different patient scenarios here, because one of the things as a general internist that I kind of wonder, and I'm sure other primary care doctors who may be watching this are wondering, is in general, I feel like I do a fairly good job of taking care of patients who come in with heart failure, and I have patients with heart failure that I follow as an outpatient. But things are getting kind of more complicated nowadays, both outpatient and in the hospital, for a general internist to take care of heart failure. Tony, when would you really say, cardiologist needs to come on board and help a general internist? And I wonder if there's things that maybe I'm not aware of that you guys could bring to the table with your heart failure team that would really be helping my patient more that I don't know about.
Well, I think that's a great point. The majority, you're right in that the majority of patients who are admitted to the hospital with heart failure are the quadrant that we call warm and wet. Those are the patients who have a decent blood pressure. A lot of times they're hypertensive. They're well perfused. They're warm. They don't appear to have low cardiac output, but they're volume overloaded. They're congested. Those are the patients with the standard heart failure order sets. You give them IV diuretics. You monitor their electrolytes and creatinine. You get them up titrate or start them on their ACE inhibitor, their beta blocker, their aldosterone receptor blockers. They diurese, they feel better, their creatinine's stable, and they go home.
Is this within 24 hours?
I think you typically will see a diuresis in the first 24 hours. Now, one of the things that I see people sometimes try to do is try to diurese these people more quickly than you can. Remember, you can only diurese what's intravascular. So, yes, you can diurese patients for a period of time, but you have to let that extravascular congestion or volume re-equilibrate. So that, I think one of the things I see the residents doing is trying to diurese patients with TID IV Lasix. Well, you're going to make them pre-renal, and you're going to put them in acute renal failure. So sometimes the very volume overloaded patient takes time. You can't rush it. So maybe after the first day or two, you may have to back off the diuretics for a little bit if they're not what we call optimum volemic. They're back to their baseline. Yes, they may not be euvolemic, but they may, because they may have a little edema at baseline. So I think those patients who have a blood pressure, who have a decent creatinine and renal function, and you can successfully diurese in that first 24 hours, those are patients that probably can be well managed by general cardiology and internal medicine. I think when you get into trouble, the patient doesn't diurese. They gain weight instead of lose weight. Their creatinine goes up. Those are the patients you might want to think about a cardiology or a heart failure consult, because those are the patients that may need, as Bethany pointed out, they may need invasive monitoring to measure their filling pressures or to initiate IV vasodilators such as nitroprusside.
Now you've got, I know a full team of people that are coming at the patient with heart failure. So how does your team work? What's going to happen with your nurse practitioners, with people that are there to make sure that the discharge happens appropriately? All that. What's the team approach you're taking?
Yeah. So if we get consulted from the heart failure perspective, the initial approach is that the mid-level provider, the nurse practitioner, will go scout out the patient, get things in line, review the case with one of the 7 heart failure specialists in the practice. We'll come by, see them in consultation. And then on top of that, we have case managers in heart failure who make sure that, you know, we're achieving those reportable performance measures.
Mm-hmm.
The other aspect is there is increasingly good data that says when you dismiss a heart failure patient from the hospital, they should have close follow-up. What do I mean by that? That may be a phone call within the next 24 to 48 hours, and usually an outpatient return follow-up visit within a week. And we will make sure that happens with the heart failure team, whether with a mid-level provider in our outpatient heart failure clinic or with one of the cardiologists.
And then also when we talk about the critical access hospitals, because we've got Anderson County, Hedrick, and Trenton, if a doctor up there is having trouble with their heart failure patient, what do they do?
Well, we're certainly available by phone, or if they would like to transfer the patient, we're certainly available, you know, to readily accept that patient. They may initially come to the general cardiology service and then get consulted by the heart failure service.
Now, there's also another, I know, heart failure option that in your armamentarium here at the plaza where you're using ultrafiltration. That's always been a little bit of a mystery to me as to when are you as a cardiologist deciding this patient needs ultrafiltration, and what's the efficacy that you've seen on it?
Yeah, it's a mystery to us too. But we did participate in I think the landmark trial that showed that ultrafiltration is effective, called the UNLOAD trial, published in the Journal of American College of Cardiology in 2007. So this was a trial that basically it's like a renal ultrafiltration, CRRT, except it can be done at the bedside with what we sometimes call a little blue machine or what have you, and it's very little extra corporeal blood volume, so it doesn't cause hypotension. We have specially trained nurses on the cardiac floors that know how to use this device. It can be run with either a central line or a special PIC line. And the UNLOAD trial showed that by taking off fluid by means of ultrafiltration versus intravenous diuretics, that not only were you able to take off more fluid, but outcomes out to 3 months in terms of rehospitalizations were significantly reduced. Which patients do we choose? I think there are several. Again, I think it's the complicated heart failure patient. I think it's the patient that we see on a routine basis with chronic heart failure. It may be systolic, maybe diastolic, where they're more than 10 pounds volume overloaded. So the patient who comes in with massive anasarca, and you know by just looking at them that they're over 25 pounds volume overloaded. Sometimes we use it as a backup measure in patients who don't diurese effectively, for example, or those patients who might develop hyponatremia with diuresis, or those patients who bump their creatinine when you're trying to diurese them. So those are the patients, again, those complicated heart failure patients that may in fact benefit from ultrafiltration, which takes off an isotonic fluid versus diuresis with intravenous diuretics that takes off a hypotonic urine. So
There's a good way to think of it.
Yes.
Tony talked a little bit about the warm and wet patient. You're talking more about the patient that's
Cold
cold
and wet.
and wet.
Yeah.
And so take me through, is the patient, you're meeting them in the emergency room when this is getting initiated, or are they already going through the part of the hospitalization and then they're deciding you try the vasodilator therapy?
Sure. Typically, we're either accepting patients in transfer from other hospitals with cardiogenic shock, and we accept them to the ICU and on clinical assessment feel that this would be appropriate and that they need invasive monitoring, or they've been seen in our heart failure clinic and they're being admitted for evaluation for advanced treatment options, potentially transplant or mechanical circulatory support. And as part of their evaluation or treatment, we feel that this would be helpful in optimizing their status. So they're usually, I'm sure people could come through the emergency room and whatnot. It seems they usually have been evaluated at some step along the way to be deemed, someone has already recognized that they're quite ill.
Now, on the sodium nitroprusside order set, I remember that the nitroprusside is one of those things that can maybe give me cyanide toxicity over several days. How long is the patient potentially going to be on the nitroprusside? How long are you using
Sure.
it?
Usually, if you're going to see a thiocyanate toxicity, which is exceptionally rare, it's at high doses and over long periods of time, at least 3 days or more. At the doses that we typically use, even over long periods of time, it would be unusual. But you can do routine monitoring every few days if you do have someone who's, for instance, waiting for transplant and you have a Swan catheter in place and they're just being maintained on a nitroprusside infusion. But it's quite rare. One other thing that you can see with potential side effects is shunting and hypoxia from underperfused or overperfused, underventilated lung segments. So if you do have sort of acute hypoxic response following initiation of that, it's something to think about.
Well, I want to tell you both, thank you very much for being with us today. This has been really helpful. I hope that the people out there that are watching would be considering using the order sets prepared for congestive heart failure, as well as contacting our cardiology colleagues here when things get a little bit rough or out of hand with your patients. Thank you very much, both of you.
Thank you.
Have a great day.
Thanks so much.